Hello and welcome to the Dementia Doctor. Today I have a very special guest with me, Dr. Denis Kay. He is joining us from Alpha Cognition. He's the Chief Scientific Officer, and he's going to talk more about his research and tell us interesting findings with the new drug that he's been working on.
Wonderful. Happy to join you, Dr. Verma, and talk about Benzgalantamine, which received FDA approval for the treatment of mild to moderate cognitive deficit in Alzheimer's dementia, and was launched earlier this year in April throughout long-term care facilities in the US. It's available by prescription throughout the US. And this is a prodrug of an already marketed cholinesterase inhibitor, galantamine, and it was specifically designed to reduce systemic gastrointestinal side effects. These are often dose and duration of treatment limiting. They're the classic cholinesterase inhibitor side effects of nausea, vomiting, and diarrhea. Not pleasant at all for anybody. The drug is an inactive prodrug of galantamine. It's absorbed largely as an inactive drug in the small intestine, is converted to active galantamine in the liver, and then acts on the brain as galantamine did, but without the systemic side effects. This is a key differentiator for this drug. And now we're examining the drug for an additional indication, traumatic brain injury. The work that we did previously was all Alzheimer's disease focused, but we think that the drug has the potential to treat folks who have suffered a traumatic brain injury, either acutely after the injury. And I like to think of this as any traumatic situation where treating early and effectively has the best possibility for patient outcome. So we've looked at two specific animal models for traumatic brain injury and determined that this drug limits the extent of the injury, limits the neuropathology that develops subsequent to the traumatic brain injury, and improves outcomes. In a rat model, and these are both preclinical or animal studies, we saw effective recovery to the point where we couldn't distinguish the behavioral outcomes from uninjured animals. So they effectively return to a pre-traumatic brain injury state. In a second model, we subjected the test animals to repetitive mild traumatic brain injury. And this is really, it's a concussive, just a big puff of air that moves the animal and has the same effect as somebody in service who would be subjected to a mortar explosion or to some other large concussive force. And in this second model, we saw, again, preservation of the reduced neuropathology, and most importantly, reduced evolution of toxic hyperphosphorylated tau. This is a protein that is implicated in the neuropathology, both Alzheimer's disease and traumatic brain injury, and the same species of phosphorylated tau that evolve during the evolution of Alzheimer's disease are evident in the animals and reduced, significantly reduced by the treatment with the prodrug. Again, the key thing here, we believe, is to be able to treat quickly and effectively with a well-tolerated and a safe version of galantamine. There have been previous studies, animal studies with galantamine, but no human clinical studies, because if you give an effective dose of galantamine to a patient without titrating the dose up over several weeks, it's not tolerated at all. So it's impossible to treat acutely with galantamine after a TBI. And patients are often disoriented and nauseous to begin with from the head trauma. And so this prodrug offers the potential to have a well-tolerated, safe, efficacious dose given immediately after the trauma. A second very important indication for traumatic brain injury, and this is where we're going to begin our clinical assessment of the prodrug in TBI, is to improve cognition in long-term sufferers. In the traumatic brain injury world, if you have symptoms that don't resolve after 3 months, then you go from an acute and subacute to a chronic phase, and it's the persistent chronic cognitive deficit that is suffered by a minority of patients, but still a significant number because there are approximately 2 million visits to emergency rooms throughout the United States every year from traumatic brain injuries. And that's an underestimate of the total number, of course, because many people, even suffering quite a significant blow to the head, don't seek immediate care for the traumatic brain injury. So I hope that has given you some indication of where we plan to take this drug. At the moment, we're doing a final phase of reformulation so that we can provide the drug to patients as a sublingual, rapidly dissolving tablet. Because again, after TBI, many people simply can't take anything by mouth. So the current formulation of the drug as an oral delayed release tablet wouldn't be an effective way to treat a traumatic brain injury patient.
This is all very exciting and so much to unpack with just one medication.
It
Um,
is, it is.
yeah, yeah. So just to kind of summarize everything that you told us, so benzgalantamine is a similar drug that is used in memory clinics, and it's been used in memory clinics for about more than 2 decades, including donepezil and galantamine. And your drug is a prodrug, so it does become galantamine once it's in the liver, and it's in for memory, it has the approval to be utilized in United States. Is that correct?
Yes. It has the same indications for treatment that galantamine or the I believe Reminol is the trade name
Yes.
generic galantamine,
Okay.
but with the improved outcome of reduced side effects.
With reduced GI side effects.
That's correct.
Since it is not going to the tummy and it's not active when it's still in the tummy, as soon as it goes to the liver, that's where it gets activated and then it just goes to the brain.
That's it. That's it.
Yes.
And it's very heartening to see the early outcome in patients that are being treated. We have
Mhm.
some excellent we have what we believe is a very safe and an effective way to manage the early and moderate stages of dementia. The one other thing I would say about galantamine is that it has a second mechanism of action. In addition to being an acetylcholinesterase inhibitor, it modulates nicotinic receptor function, meaning it sensitizes nicotinic receptors to the the acetylcholine that they normally respond to. And the two receptor populations that we're very interested in traumatic brain injury and in Alzheimer's disease are named two variants of the nicotinic receptor called alpha 7 and alpha 4 beta 2. Both of these are modulated to increase their function by up to what you would normally see as a maximum in a healthy neuronal population, but not in excess of the maximum. So with reduced acetylcholine levels, one sees optimal functioning of the nicotinic receptor system, in addition to an elevation of acetylcholine levels by acetylcholine esterase inhibition. It's quite a mouthful to get it all out.
Certainly, it's quite a mouthful. And to simplify for our listeners, acetylcholine is an attention chemical, and we are just trying to maximize this attention chemical in our brain. And that's why it can be used in a variety of problems like Alzheimer's, vascular dementia, as well as TBI that we are now learning. And the way we increase the levels is by blocking the enzyme that breaks it down, and that enzyme is called as acetylcholine esterase. And the pills like donepezil, galantamine, benzgalantamine, all these pills will go and block that enzyme. And that is why they are called as acetylcholine esterase inhibitors. And what Dr. Kay mentions is that in addition to this blocking of this enzyme and maintaining the high levels of attention chemicals in our brain, we are also, in a way, modulating the other receptor, that is the nicotine receptors, which are also sensitive to this chemical. So we are maximizing the effect of having high attention chemicals in our brain. Now, I do see in the clinic that with my prescriptions of donepezil or these class of medications, the major reasons for discontinuation is almost always a GI side effect, where they will come with nausea, vomiting, diarrhea. And to know that we have a medication available that does not give that side effect because it kind of surpasses the stomach and goes to the liver. And I believe it's the lipophilic or fat-loving property of this medication that it goes to the brain.
That's correct. That's correct. Well, the galantamine has a slight preference for brain over blood. But the key aspect of the design and the administration route of administration of Benzgalantamine or the trade name ZUNVEYL is that it's absorbed across the intestinal epithelium largely as an inert prodrug and then gets converted after it reaches the liver and goes through the blood to the brain where it exerts its action. It has a number of fascinating clinical effects. The clinical experience with galantamine, when epidemiologists have looked at many years of patient experience in national registries, and the most impactful or the most prolific work has come from Sweden, from the Karolinska Institute. And this isn't work that was sponsored by any drug company. It was an academic assessment of patient outcomes over 5 years. And galantamine, relative to the other members of the class, donepezil and rivastigmine, had the strongest benefit for patients. It was the only drug that moderately, again, moderate, it's not a cure, but it is an effective treatment, moderately slowed and statistically significantly slowed progression from moderate to severe dementia. It also has the strongest outcome in terms of reducing mortality, all-cause mortality. Now that in of itself is we're all going to leave this world one way or another, but by reducing mortality and morbidity, most importantly, it reduces hospital visits, it reduces cost of medication and the cost of managing patients in long-term care facilities. So we're very excited about the potential to help patients with an effective and well-tolerated alternative acetylcholinesterase inhibitor.
And in that, along the same line of talking that we're doing, the traumatic brain injuries is a largely underserved, under-recognized area of brain injuries. And I think
No
just the
question.
other day you had mentioned that a lot of families and patients stop going to the clinic. So we truly do not know what is the number of individuals who are suffering from chronic traumatic brain injury because
Right.
they just feel that there's nothing much, you know,
Mhm.
improvement that they're making. So currently, the drug is in the preclinical stage for this indication, correct?
That's correct. It is.
Yes. Yes.
And once we finish the reformulation so we can administer it in a sublingual format, something that a traumatically brain injured patient could tolerate, our intention is to go later this year to the FDA with a plan for the clinical development for traumatic brain injury, focusing on those that probably 10 or 15% of people who suffer a mild traumatic brain injury will have some symptoms, cognitive symptoms that persist for more than 3 months. Some of those patients will normally and naturally improve over time. However, others will not. And it's the population that has a persistent cognitive complaints for more than 3 months that we really believe we have an opportunity to help.
Now, Dr. Kay, while you were describing the different mouse models or different ways of doing the study, I found it very interesting that one of the model had one bad injury and the other one had repeated minor injuries with the blast
Right.
of air. That's kind of simulating two possible conditions that we see in real world, having a motor vehicle accident or having individuals who play contact sports like football who have repeated concussions. So
Yes.
um, I understand that this would be something that would be beneficial to the larger population.
Well, at the moment, and as you mentioned just a few moments ago, that the traumatic brain injury is an medically under addressed or underserved condition. There are no approved medications to directly impact the pathophysiology. Typically, patients are given anti-nausea medications or sleep aid medications if one of the long-term outcomes of unresolved traumatic brain injury symptoms is sleep disruption. For a variety of reasons, we believe that the nicotinic modulator, acetylcholinesterase inhibitor of benzgalantamine is going to have an impact on more than simply cognition, but that's our first indication is cognition.
Yes, and the information that we get from the preclinical animal models, and the fact that we learn that there is an effect on the phosphorylated tau or p-tau that we
Right.
know is so crucial for development of Alzheimer's disease, as well as the fact that even a single traumatic brain injury increases your risk of having dementia significantly. Just having
Yeah.
that information and seeing in the clinic individuals who are in football players or boxing players seeing a development of dementia. So in those individuals as well, this would be a medication that could address both of the issues.
We're very hopeful that in addition to dealing with the symptomatology that the patient presents with at clinic, whether it's a chronic deficit in cognition or whether down the road, if we're able to assess this in acutely injured patients, in the evolution of neuropathology in Alzheimer's disease, there are stages of the development of both amyloid and tau pathology that were designated by a husband and wife team, the BRACs. So BRAC stages 1 to, I think, 6 in tau pathology. Tau pathology emerges about a decade before amyloid pathology does. And if 3 years ago, Heiko Brack and his colleagues, Arnsten was the first author in this manuscript, posited that the early emergence of tau pathology and the fact that tau pathology better correlates with cognitive regions where cognitive deficit is emerging, that its preeminence in time, the fact that it shows up first before amyloid pathology, they posited in this manuscript that if we're able to reduce tau pathology by any therapeutic intervention, that given enough time and started early enough, and this would be the case if you treated somebody with a traumatic brain injury and were able to reduce and document that, like in animals, in humans, we also see reduced hyperphosphorylated tau. The biggest outcome in the second study, the most impactful reduction, is something called phospho-tau 217 reduction. And that, as we know, is one of the plasma markers that has been assessed for in the FDA-approved assay for early stage diagnosis, or I wouldn't say diagnosis, but for an indication that further investigation should be made if somebody's showing up at a memory clinic and they have a positive p-tau 217 and amyloid plasma marker, then that they ought to be investigated further for early stage Alzheimer's disease. So we're very hopeful that we may be able to reduce the likelihood that folks who are treated with benzgalantamine after a TBI may have a reduced lifetime risk of developing a dementia.
Yeah, that in itself would be a very great achievement as we don't have anything right now in that
No.
regard.
Yeah.
And one of the other things that you highlight during this discussion is there is this competing views in the field about amyloid hypothesis and tau hypothesis, and which one comes first and which one. Of course, there's no doubt about how tightly tau is related with shrinkage in the brain as well as clinical symptoms. But this just tells us how complex Alzheimer's disease is and how we all are trying our best to figure out how to treat this the best way possible.
Absolutely. And at the meeting we both attended in San Diego a few weeks ago, some of the current clinical trials that are looking at joint administration of both amyloid and tau active therapeutics. I think these trials, together with diet and lifestyle intervention, will likely give patients a real measure of hope that the community hasn't had up until very recently. So I think we're turning a corner in Alzheimer's disease detection and treatment. We're not quite there to a cure yet, but it's certainly something that we're all working very hard to achieve.
Yes, I agree. It's one of the most exciting times to be living in if we are someone who is working in the field of Alzheimer's, and combination therapies are up and coming, and
Mm.
it would be very interesting to see how the results are different from amyloid only or tau only therapies. And we also have known anecdotally that individuals may have amyloid and a lot of amyloid in their brain and never get Alzheimer's disease. So that's another mystery and raises questions about amyloid only therapies as well.
That I agree. The analogy that people have used is cancer. Cancer therapy very often involves two or three, or often more, different therapeutic approaches to manage the malignancy. And it's become very clear throughout many decades of clinical studies in Alzheimer's disease that a silver bullet, a single therapeutic approach, will likely never be effective. A combination approach and a patient specific, potentially tailored to the specific patient's genetic background, their life history, may be the best way to address dementia progression.
I agree. This has been a very exciting and a fruitful discussion. I also wanted to ask you, is there anything else that you would like to share with our listeners about the research and about your work?
I'll just put a little plug in for a study that we're designing. Of all three class members of cholinesterase inhibitors, galantamine is the only drug. Again, these studies are not sponsored by any drug company. These were meta-analyses of multiple clinical trials, as well as longitudinal reports of outcomes in national health registries. Galantamine is the only member of the class that either has a neutral effect on sleep or a slightly beneficial effect. And I say slightly beneficial because these were two small trials. They weren't placebo controlled. They were investigator initiated open label trials, but where both caregivers, patients, and physicians indicated that the patients being treated with galantamine had improved sleep. Sleep loss of sleep quality is almost universal in dementia, not only in Alzheimer's disease, but in vascular dementia. And it's an early, very early emerging deficit, even in mildly cognitively impaired folks. Sleep quality and sleep structure is compromised. Most importantly, in mildly cognitively impaired individuals, when you look at their sleep, the phases of the sleep cycle that they go through, they have very compromised N non-REM phase 3 sleep, which is the deepest phase of sleep, where the garbage system, the garbage trucks that clear all of the waste from our brains are most active in this phase of sleep, and it's absent in these patients. We're designing a clinical trial to look at the outcome in mildly and mild AD and MCI patients, to look at the sleep structure and sleep quality. And we hope to be able to provide evidence of improved sleep quality with this study. So that's the only other thing I'd add.
Yeah.
Otherwise, otherwise we'd be here for a long time. We have lots of great, we have great hope for the future of this drug.
Absolutely. And I often say to my families that dementia is not just a memory problem, it's a whole body problem. So we're looking at your mood, we're looking at your sleep. And as you said, the deepest stage of sleep is where all the amyloid from the brain is removed. And if we take it away, we start depositing amyloid in the brain. And the other thing that is highlighted with this discussion is the fact that if we have a single drug that addresses different factors, so this class of
Mhm.
drug is known to affect mood and sleep and memory at least. And what
Right.
we are discussing here is that galantamine and benzgalantamine specifically have a better effect on sleep as compared to donepezil or rivastigmine.
Right.
And your hope is to also demonstrate that in a clinical trial by measuring and studying the sleep stages.
That's correct.
Yes, yes, yes.
Fingers crossed.
Yes, absolutely. Best of luck for that research. This all sounds really exciting, and our families love to hear about the hopeful research and individuals like you who are working day in and day out for our families. We are very grateful for you to come and talk to us and describe your research to us. Thank you so much, Dr. K. You have the rest of the wonderful day.
Thank you. Thank you, Dr. Verma.